we'll be breaking down all major concepts covered on the exam.
Yes, and we are going to get into some really fascinating structural mechanics today.
Definitely. I mean, imagine a patient who comes into your clinic complaining that they just keep sustaining severe burns on their hands while cooking.
Ouch. Yeah, that's a classic presentation.
Right. Like they never feel the heat of the stove or, scalding water, but they have absolutely no problem feeling the texture of the sponge they're holding or the vibration of their phone.
Which is such a bizarre, highly specific sensory deficit.
Exactly. And understanding exactly why it happens is going to earn you crucial points on your exam. We are your dedicated MCCQE reviewers, and our whole mission is to help Canadian medical students feel, well, fully comfortable and incredibly confident with the exam review process.
Because that transition from the, theoretical world of textbooks to the practical realities of the wards and ultimately to passing your board exams, it requires a deep understanding of pathophysiology, not just rote memorization.
Oh, totally. We're here to synthesize all that noise and focus on the clinical mechanisms that actually matter. And I should mention, today's teaching comes directly from reliable StatPearls articles.
The best.
Yeah, we are going straight to the gold standard of peer-reviewed clinical info so you can trust the material we're unpacking today.
But before we jump right into the pathophysiology, just a really brief disclaimer. This deep dive is for medical education only, not medical advice. All clinical decisions in the real world should involve a qualified healthcare provider.
Perfect. So today we are opening up the S08 Neurology section, and our focus is on spinal disorders. Specifically, we're going to unpack spinal stenosis and Syringomyelia.
Two heavy hitters on the exam.
Right. And for you, the listener, the reason these two are grouped together is that they both involve severe structural crowding in the spinal canal. But they actually attack the neuroanatomy in completely opposite directions.
That's a great way to put it.
Yeah, so one is an outside-in compression problem, while the other is an inside-out expansion problem. And I'm telling you, the MCCQE loves testing your ability to tell them apart based on their clinical fingerprints.
Oh, absolutely. Grasping the biomechanics and the fluid dynamics behind these conditions is incredibly high yield for the boards. It will fundamentally change how you approach neurological deficits in practice.
So let's establish our baseline. We'll start with the more common condition you'll see on your internal or family medicine rotations, which is spinal stenosis.
Right, our outside-in compression.
Exactly. And we're usually talking about the geriatric population here, especially lumbar stenosis for patients over the age of 65. So I want to understand the exact anatomy of this squeeze. Where precisely is the space narrowing?
Well, there are three specific anatomical sites of narrowing that you have to conceptualize for the exam. First is the central canal,
Okay.
which houses the spinal cord in the cervical region, and the cauda equina in the lumbar region. Narrowing here is typically in the anterior-posterior dimension. Second is the neural foramen. This is the actual lateral opening, where the nerve root exits the spinal canal to become a peripheral nerve.
Got it. Then the third.
The third is the lateral recess. Now, this is a zone specific to the lumbar spine. It's the pathway along the pedicle that the descending nerve root traverses right before it prepares to exit.
Okay, so to make this easier for the listener to visualize, let's use a highway traffic jam analogy.
I love analogies. Go for it.
So central canal stenosis is like a massive blockage on the main highway, right? Everyone is stuck.
Yep, full stop.
Then lateral recess stenosis is like traffic backup specifically in the exit lane. You're still on the highway, but you're trapped in that specific lane trying to get off.
Perfect.
And finally, neuroforaminal stenosis is a blockage right on the off-ramp itself.
That is exactly how you should think about it. And that highway analogy helps explain the etiologies you'll be tested on, too.
Because it's mostly a wear and tear issue on the roads, right?
Yeah. Exactly. I mean, about 9% of cases are congenital, like achondroplasia, where the pedicles are just abnormally short from birth. But the vast majority are acquired.
Right.
The testable acquired causes are mostly degenerative changes. So as the intervertebral discs desiccate and lose height with age, the surrounding structures have to compensate for the altered load.
They have to pick up the slack.
Yeah, and the ligamentum flavum, which runs vertically along the posterior aspect of the canal, it begins to lose its elastin and accumulates collagen.
Oh, so it gets thick and rigid.
Right, it hypertrophies and physically buckles inward into the canal space.
So the body is basically trying to stabilize a degenerating joint, but in the process, it overbuilds the tissue and just chokes off the nerves.
Precisely. You also see spondylolisthesis, where one vertebral body slips anteriorly over the one below it.
Ouch.
Yeah, that creates a shear force that acts like a guillotine on the central canal and the bilateral foramina, and you must keep iatrogenic causes in mind, too.
Like previous surgeries.
Exactly. Patients with previous laminectomies or spinal fusions, that alters their spinal biomechanics, leading to adjacent segment disease where profound stenosis develops just above or below the fused hardware.
Wow, okay. So let's translate this anatomical traffic jam into the clinical presentation. If a patient is sitting in the exam room, how does this outside-in compression actually manifest? Let's start with cervical stenosis.
So in the cervical spine, the presentation depends entirely on whether that blockage is on the off-ramp or on the main highway.
Right.
If the stenosis is isolated to the neural foramen, you see radicular symptoms. The classic board scenario is C6-C7 foraminal narrowing. This compresses the C7 nerve root.
And what does that look like?
The patient presents with lower motor neuron signs, weakness in triceps extension, a wrist drop, and paresthesia radiating down into their second and third finger.
Okay, so that's the isolated off-ramp. What happens if the central canal in the neck, the main highway, is narrowed by, say, more than 30%, and the spinal cord itself is compressed?
Well, then you cross the threshold into cervical spondylotic myelopathy. This is no longer just a trapped peripheral nerve root. This is central nervous system compression.
That sounds a lot worse.
It is. These patients present with upper motor neuron signs below the lesion. They develop ataxia, a spastic gait, hyperreflexia, a positive Babinski sign.
Oh, wow.
Yeah, and profound clumsiness in their hands. They might tell you, they can no longer button their shirt or turn a key in a door.
Okay, that makes sense. Let's move down to the lumbar spine now, because this is where a classic MCCQE trap lives.
Yeah.
The classic presentation for lumbar stenosis is neurogenic claudication.
Yes, very high yield.
But I want to understand the exact mechanism of the pain here. Like, why does a compressed nerve cause cramping in the legs and buttocks, specifically when the patient is standing or walking?
It's a great question. The pain of neurogenic claudication is fundamentally ischemic pain.
Ischemic, not mechanical.
Well, it starts mechanical. The nerve roots of the cauda equina are supplied by these tiny blood vessels called the vasa nervorum. When a patient is standing upright or walking, the metabolic demand of those nerve roots increases. They need more blood.
Right, they're working harder.
But the structural stenosis physically compresses those tiny blood vessels. The nerves cannot get the oxygen they need to fire, leading to ischemia, which the patient feels as a deep, heavy cramping or burning in their legs.
Ah, okay. And this perfectly tees up one of the most high-yield clinical pearls on the exam, which is a shopping cart sign.
Yes, you have to know this.
Patients will tell you that the pain is agonizing when they walk upright, but if they sit down or lean forward like they're hunching over a shopping cart at the grocery store, the pain just vanishes. Mechanically, what is happening to the spinal canal when they lean forward?
So, spinal extension, which is standing perfectly upright, exacerbates the anatomical bottleneck. It pushes bulging discs further backward and makes that hypertrophied ligamentum flavum buckle deeper into the canal.
So it tightens the squeeze on those blood vessels.
Exactly. But spinal flexion, leaning forward, pulls the ligamentum flavum taut and stretches the posterior elements apart. It literally opens up the spinal canal. The physical volume of the space increases, instantly relieving the mechanical compression on the blood vessels.
And oxygen gets back to the nerves.
Exactly, which stops the ischemic pain.
And this is how you differentiate it from vascular claudication on the exam, right?
Right.
Like a patient with clogged arteries in their legs will get relief just by stopping and standing still because their leg muscles stop demanding oxygen.
Right.
But a patient with neurogenic claudication has to actually alter the angle of their spine. Standing perfectly still upright won't help them. They have to lean forward or sit down to unkink those vessels.
That distinction is a guaranteed exam question. And to complete the lumbar picture, the MCCQE will often test your localized neuroanatomy here. The two most common sites for lumbar stenosis are L4-L5 and L5-S1.
Okay, I always get turned around on which nerve root is actually affected at those specific levels.
It's a very common trap. In the lumbar spine, a paracentral herniation or lateral recess stenosis at L4-L5 will typically spare the exiting L4 root and compress the descending L5 nerve root.
Okay, L5, so what's the deficit?
Weakness of ankle dorsiflexion. The patient presents with a foot drop. They'll drag their toe or slap their foot against the floor when they walk.
Right.
And a level lower, at L5-S1, the descending S1 root is compromised. This knocks out ankle plantar flexion. The patient will be completely unable to stand on their tiptoes.
Okay, perfect. That covers our outside incompression. The bones and ligaments are choking off the nervous system. Now, let's completely flip the script. We are transitioning from external structures crushing the cord to an internal issue that is expanding and destroying the cord from within.
Right, syringomyelia.
Yes, syringomyelia. What exactly is this?
So syringomyelia is a profound disruption of cerebrospinal fluid circulation. It's a hydrodynamic failure that leads to the formation of a fluid-filled cavity, a syrinx, directly within the parenchyma of the spinal cord, or expanding from the central canal.
So it's essentially a pocket of fluid ballooning inside the cord. But how does that fluid get forced into the solid tissue in the first place?
To understand this, we have to look at the prevailing biomechanical consensus, which is Oldfield's piston theory.
Oldfield's piston theory.
Yeah. Before this, there were older ideas like Gardner's water hammer theory, but Oldfield's is the current understanding. It all starts with the cardiac cycle. Every time your heart beats, during systole, a surge of arterial blood rushes into the brain.
Right.
And because the skull is a rigid, closed vault, the brain physically expands slightly with each pulse. Normally, to accommodate this expansion, cerebrospinal fluid is displaced downward through the foramen magnum at the base of the skull and into the spinal subarachnoid space.
So the body has this built-in shock absorptism to manage the pressure of our own heartbeat.
Exactly. But in a patient with a Chiari malformation type 1, which, by the way, is heavily associated with the vast majority of non-communicating syringomyelia cases, the anatomy is abnormal.
You're right. The cerebellar tonsils are displaced downward.
Yes. They're congenitally displaced downward, effectively plugging the foramen magnum. So when systole occurs, the brain expands, but the CSF cannot easily escape. Instead, those plugged cerebellar tonsils are thrust downward by the pressure wave.
Oh, wow. So they act as literal pistons.
They do. With every single heartbeat, these tonsils plunge down into the cervical spinal canal. This generates an intense, localized pressure wave. Over millions of heartbeats, this mechanical hammering forces blood plasma, ultrafiltrate, and CSF directly into the central gray matter of the spinal cord, slowly carving out that syrinx cavity.
Wait, hold on a second. This brings us right back to that bizarre clinical vignette I opened the show with. If a fluid pocket is expanding outward from the dead center of the spinal cord, why does the patient specifically lose pain and temperature sensation, but they can still feel a touch of vibration perfectly fine?
This is the ultimate neuroanatomy exam, Pearl. You have to visualize a cross-section of the spinal cord. The expanding syrinx originates near the central canal. As it balloons outward, the very first anatomical structure it encounters and stretches is the anterior white commissure.
The anterior white commissure, which is exactly where the spinothalamic tract crosses over.
Yes. The spinothalamic tract carries pain and temperature signals. It enters the dorsal horn and immediately crosses over to the opposite side by traveling directly through that anterior white commissure.
So the expanding syrinx just tears right through those crossing fibers.
Exactly. It physically severs them. This immediately abolishes the patient's ability to feel pain or temperature. But the posterior columns, which carry fine touch and vibratory sense, are located all the way at the posterior periphery of the cord.
Oh, so they're completely out of the way.
Right. They are physically distant from the central expansion, so they're perfectly preserved early on. This creates a dissociated sensory loss. And because the syrinx usually develops in the lower cervical and upper thoracic cord, the deficit usually presents in a cape-like distribution over the shoulders and arms.
Right, the classic cape-like distribution. So they can hold a hot coffee mug, feel the smooth texture through their intact posterior columns, but their destroyed spinothalamic tracts won't tell them their skin is burning.
It is a devastating presentation, and what's wild is how triggers can abruptly worsen it. Sudden head jolting, severe Valsalva maneuvers, or prolonged coughing can trigger abrupt symptoms in asymptomatic patients.
Wait, coughing? How does coughing exacerbate a fluid pocket in the spine?
Well, when you cough violently, intrathoracic pressure spikes. This prevents venous blood from draining out of the brain, causing a transient spike in intracranial pressure. That spike violently drives those cerebellar tonsils even deeper into the foramen magnum.
So it makes the piston effect even worse?
Exactly. It forces more fluid into the syrinx abruptly.
Wow. Okay, so transitioning to diagnostics. Now that we understand the pathophysiology of both disorders, how do we confirm these diagnoses on the wards, and more importantly, how do we fix them?
For diagnostics, MRI is the undisputed gold standard for both conditions.
Right. X-rays aren't going to show us a compressed nerve root or a fluid cavity.
No, they won't. You need MRI. Now, for stenosis, dynamic X-rays like flexion and extension films are still useful for showing spinal instability, like a spondylolisthesis that only slips when the patient bends forward.
Right, because laying flat in an MRI might artificially reduce the slip.
Exactly. But for syringomyelia, the imaging technology gets really cool. We use phase contrast MRI or cardiac-gated SYN MRI flow studies.
Cardiac-gated SYN MRI, what does that do?
It synchronizes the MRI pulses with the patient's ECG. It actually visualizes the CSF hydrodynamics and velocity disturbances at the foramen magnum in real time. You can literally watch the piston effect happening.
That is incredible. Okay, so we've got our MRI. Let's talk management. How do we treat the outside-in compression versus the inside-out expansion?
For stenosis, you start with conservative management first. NSAIDs, physical therapy, epidural injections. But if they develop myelopathy or progressive neurologic deficits, you move to surgical decompression.
Right, like a laminectomy to clear the highway.
Yep, unroof the canal, and a fusion if there's instability. Now, for syringomyelia, surgery aims to correct the CSF flow dynamics. For that Chiari malformation type 1, this means a craniocervical decompression.
Which involves what exactly?
A suboccipital craniectomy. They remove a little bone at the base of the skull and the posterior arch of C1 to give those cerebellar tonsils more room, stopping the piston effect.
Okay, I have to push back here. If syringomyelia is literally just a pocket of fluid, why don't surgeons just stick a shunt in it and drain it immediately? That seems way less invasive than taking off part of the skull.
It seems intuitive, but shunts, like syringosubarachnoid shunts, are actually considered a last resort.
Really?
Because they have incredibly high complication and failure rates, and they don't fix the underlying cause. If you drain the syrinx but leave the foramen magnum plugged, that pressure gradient is still hammering away during every heartbeat.
Ah, so the shunt will just fail.
Exactly. It'll clog with debris or cause the cord to tether. You have to fix the flow dynamics at the source.
Okay, that makes perfect sense. Fix the plumbing at the source.
Yeah.
What happens if we don't catch it in time? What are the prognostic indicators?
Well, a syrinx diameter over 5 millimeters and associated parasyrinx edema strongly predict rapid deterioration. Complications include severe spasticity, paraplegia, and even kyphoscoliosis.
Wait, kyphoscoliosis? How does a syrinx curve the spine?
As the syrinx expands into the anterior horns of the spinal cord, it destroys the lower motor neurons that supply the paraspinal muscles.
Oh, I see.
Yeah, without that balanced muscular support, the spine just buckles under gravity, actually reducing spinal length.
Wow. Okay, this has been an incredibly dense review, so let's quickly recap the absolute highest yield points for the listener's exam.
Sounds good.
Remember the shopping cart sign for lumbar stenosis leaning forward, opens the canal and relieves that ischemic neurogenic claudication.
Yes, very important.
And for syringomyelia, remember the cape-like dissociated sensory loss pain and temperature are gone because the anterior white commissure is destroyed, but light touch is spared. And finally, remember that MRI is the absolute gold standard for both.
Spot on. And I want to leave you with one final puzzle to ponder based on the source material.
Oh, I love these.
We talked a lot about Chiari malformations, but there is also post-traumatic syringomyelia, which commonly occurs within 5 years post-injury.
Okay.
It presents a massive clinical mystery. When a patient with a previous spinal cord injury develops new neurological deficits years later, it remains incredibly challenging to definitively distinguish whether those new deficits are caused by a newly formed expanding syrinx cavity or if they're simply delayed degenerative effects of the original cord injury.
Because they look clinically identical.
Exactly. It is a profound diagnostic dilemma that you might one day have to solve in your own practice.
What a fascinating puzzle to end on. Thank you so much for breaking this all down, and thank you to the listener for joining us on this review. We'll see you on the next Deep Dive.